Disclaimer: this presentation contains copyrighted material collected from the web sources and printed versions of pharmacology textbooks. The presentation is intended for teaching and no commercialization or marketing involved. The learners are recommended to purchase and refer the textbooks for a better learning experience. Welcome everyone. In today's class, we will discuss about hematinics. Hematinics are the nutritional supplements which aids in the development or the proliferation of blood cells. So the process of proliferation of blood cells is called hematopoiesis, so which includes formation of erythrocytes, platelets, and leukocytes, nothing but the RBC, WBC, and platelets. Okay. So basically, this process is a remarkable process which produces around 200 billion new blood cells per day. So if this many number of cells supposed to be produced per day, it requires a lot of constituents, right? So some of the major constituents required for the formation of all these blood cells include iron, vitamin B12, also known as cobalamin, vitamin B9, also known as folic acid. So if people consume these constituents properly through the dietary supplements, so there won't be any change in the process of hematopoiesis, and the people will be healthy, right? Suppose if due to dietary deficiencies, in case if the people doesn't consume sufficient amount of all these three constituents, so that could lead to anemia. Okay, so the symptoms of anemia due to any of these hematinics include fatigue, palpitations, shortness of breath, pallor means the person becomes pale, dizziness, and also insomnia. Causative factors for this anemia include chronic loss of blood. So generally, if someone loses blood due to cancers, uh, so in case of cancers, there could be internal hemorrhages within the body, and that could lead to chronic blood loss. And if someone meets with an accident, and due to accident, if someone is undergone extensive blood loss, also known as hemorrhage, or hemolysis. So, due to envenomation or any other envenomation means intoxication due to a snake bite or any other thing which leads to hemolysis means destruction of blood cells, right? In fact, not only envenomation due to toxicity. In fact, iron itself, if someone consumes a lot of iron, the toxicity due to iron itself could cause hemolysis, right? So, due to many of these reasons, this anemia could be produced. In fact, apart from those we discussed, bone marrow abnormalities. So, bone marrow is the place where this hematopoiesis will be happening. Or bone marrow suppression due to anti-cancer drugs. Sometimes bone marrow suppression happens. So, just for example, a drug known as methotrexate or many other anti-metabolites, and just for example, a drug known as azathioprine, right? So these drugs are going to cause bone marrow suppression. So if bone marrow suppression happens, hematopoiesis will be slowed down. So because of that, blood cell formation will be slowed down, and the outcome would be, or the detrimental outcome would be, reduced number of blood cells. Uh, you, so that could cause thrombocytopenia or leukopenia. So these are some other causative factors. Apart from that, chronic infections could cause anemia, any kind of endocrinal deficiencies. Just for example, erythropoietin is a hormone which is an endocrine hormone produced by the kidneys. So Kidneys could sense the level of oxygen being supplied to them. So if the kidneys becomes hypoxic, if the kidneys doesn't receive sufficient amount of oxygen, then kidneys release erythropoietin. So this erythropoietin stimulates the bone marrow to produce more and more red blood cells so that kidneys receive sufficient oxygen. Okay. So endocrinal deficiencies like erythropoietin deficiency could also cause anemia and renal failure. So the same thing. So again, in case of renal failure, erythropoietin cannot be released by the kidneys, and that's why that could also cause anemia. And nutritional deficiencies. So if someone doesn't consume sufficient nutritional food, which is rich in iron, folic acid, and vitamin B12. That could also cause anemia. And if people have any genetic predisposition to anemia, such as sickle cell anemia, in case of sickle cell anemia, um, these people would be affected due to the presence of a mutated version of beta globin in the hemoglobin, which causes the cells to which causes the hemoglobin within the red blood cells to form a chain, so which ultimately turns the red blood cell from the disc shape into the sickle shape. So I hope all of you remember the shape of a red blood cell. So generally the shape of a red blood cell would be like this. So it is a disc shape, but in case of sickle cell anemia, it turns into sickle, right? So these sharp corners in the sickle cells makes these cells viable to break when they are going through the capillaries. So you can observe these are rounded edges, which makes them to flow along with the blood nicely, right? Whereas the sharp edges will make them to break when they are going through small capillaries. Okay, so these are certain causative factors for anemia. So let us now see and start discussing about the iron. So before I start discussing about the supplementation of iron, let me discuss how this iron is going to get transported to various parts of the body. What are the functions of iron and how is it absorbed? All these things. So these are all very important for you to know before you devise a therapy for someone who is anemic, right? So first of all, the iron that you consume could be due to dietary sources such as meat or could be due to vegetarian sources, right? Or someone can take a syrup, an iron syrup or an iron tonic, right? So ultimately, all this iron would be turned into ferrous form, right? Because within the stomach, iron turns into ferrous form due to the acidic environment. Apart from that, if someone consumes iron from the meat, right? So that meat contains iron which is bound with the heme, right? So this is called heme iron, and this is called inorganic iron. So both heme iron and inorganic iron need to be absorbed. So how they will be absorbed? Inorganic iron will be absorbed with the help of a transporter known as divalent metal transporter. Divalent metal transporter 1 transports iron into the gastric cells, so intestinal epithelial cells, and heme iron will be entering into the epithelial cells with the help of another carrier protein known as heme carrier protein (HCP). This is divalent metal transporter, and HCP is heme carrier protein. So these two carrier proteins carry them into the epithelial cells. Within the epithelial cells, this iron would ultimately bind with a protein called as ferritin. Okay, so F means ferritin. So within the intestinal epithelial cells, it is stored in the form of ferritin. Whenever it needs to be absorbed into the blood, because iron has a property to oxidize, and it is going to produce free radicals. So our body has a protective mechanism in transporting iron. So you can observe generally within the intestinal lumen, you can clearly observe iron is present in the form of ferrous, right? But once it enters into the blood, it turns into ferric, Fe3 plus. Okay, so for the absorption from the intestinal cells into the blood, again another transporter known as ferroportin, and another transporter known as ferroportin transports the iron into the blood. Okay, again within the blood, again the iron cannot travel as such, because this Fe3 plus is also highly uh, um, reactive, and particularly it can participate in a reaction called Fenton's reaction, and which liberates a lot of free radicals, superoxide radicals, and that's the reason why your body always transports this iron in the form of transferrin. Okay, this is transferrin. So this transferrin transports iron always bound with the a transferrin enzyme. Okay, so this iron would then enter into the bone marrow. Okay, the function of iron is to participate in the hematopoiesis, and within the bone marrow, this iron will be absorbed. So for the absorption of this uh, transferrin into the bone marrow, there should be some receptors again. So these are TFRs. This is TF transferrin, and these are transferrin receptors. Okay, so transferrin receptor is this transferrin is bound to transferrin receptor, and this whole thing will be internalized, and within the bone marrow, within the cells of bone marrow, both the transferrin as well as transferrin receptor, both transferrin and transferrin receptor will be liberated, and only iron will be extracted. This iron will then be utilized for the production of red blood cells. Okay. Apart from that, iron also enters into hepatocytes. Okay. This transferrin enters into hepatocytes with the help of transferrin receptors, and within the hepatocytes also, it is going to get stored in the form of ferritin, as we just discussed earlier. Ferritin is the storage form of iron, which stores in the intestinal cells and also hepatocytes. Okay, and from there also, whenever required, so this iron will be liberated through the ferroportin. It is going to come out through the ferroportin, and then iron also enters into spleen. Right. So how does this iron enters into spleen is, so those old cells, senescent RBC. So senescent RBC means these cells become aged. Okay. So aged red blood cells will undergo recycling. So these aged red blood cells will be broken, and the constituents of these broken red blood cells will be extracted by the splenocytes. So means cells present in the spleen, and also macrophages. Okay, macrophages and splenocytes break the old red blood cells and take the constituents. So what are the constituents? Hemoglobin. Okay, so hemoglobin will then be extracted to produce the iron. Okay, and further, these macrophages and spleen also stores this iron in the form of ferritin. And sometimes, whenever required, through the ferroportin, it is going to transport the iron into the blood circulation. So ultimately, iron is going to be stored in the splenocytes, macrophages, hepatocytes, and also intestinal epithelial cells. And whenever your body has sufficient amount of iron, let's say your body has sufficient amount of hemoglobin and sufficient amount of iron, then your body itself has a negative feedback mechanism to inhibit the absorption of iron. So in your diet, whatever the iron that you consume will go into the gastric lumen and stores over there. And whenever your body already has sufficient amount of iron, this will not be transported. Okay, this will not be transported due to the presence of an enzyme called hepcidin. Okay, so this hepcidin inhibits the transportation of iron from the ferroportin. Hepcidin inhibits the transportation of iron from the ferroportin. So with this, in this manner, when your body has sufficient iron, hepcidin is released. Suppose if your body doesn't have sufficient iron, okay, then another hormone or another constituents released by the bone marrow called as erythroferrone. Okay, this erythroferrone does opposite activity to the hepcidin. What this erythroferrone does is it inhibits the activity of hepcidin. When the activity of hepcidin is inhibited, ferroportin transports the iron into blood circulation. Okay. So when erythroferrone is activated, when the person is deficient of iron, okay, when the person has more iron, then hepcidin is activated. Okay. Then hepcidin do not let the iron to come in. That means hepcidin stops the absorption of iron because already sufficient iron is there in the body. And when there is low iron, then this stimulates erythroferrone. This erythroferrone inhibits the hepcidin. Erythroferrone inhibits the hepcidin and allow the ferroportin to transport the iron into the blood. That means due to the deficiency of iron, ferroportin is now allowing the iron to get into the blood. Okay, so that deficiency will be restored. Okay, so this is how iron is moving along various parts of your body. Let us now see what is iron deficiency and what are the causes of iron deficiency and how the symptoms would be observed due to iron deficiency. So, so this is iron deficiency is the most common cause of anemia as we discussed earlier, and it occurs during inadequate intake of dietary iron or due to chronic blood loss. If someone has a chronic blood loss due to, so we already discussed, due to cancers or due to any kind of hemorrhages, or especially in the women who are menstruating, or the pregnant women, and especially people at the puberty. So this is not only for the women, this is also for the men. So during the puberty, your body has increased demand for the production of the blood cells. So this demand can consume more of your body's iron and could create more demand, which ultimately leads to deficiency if a person is not sufficiently taking the iron supplements or dietary iron. Okay, so that is the reason why in the pregnant and during the puberty, as a prophylaxis means as a prevention, iron is given as a food supplement or a nutritional supplement. So supplementation of iron is indicated in case of iron deficiency anemia. So that is the common reason why you need to supplement. Apart from that, megaloblastic anemia is an another anemia, so which we will discuss in today's class itself. In that case also, iron supplementation is warranted, and in case of folic acid therapy also, iron supplementation is required. Then supplementation of iron will be performed with 3 to 5 milligram per kg of elemental iron. Okay, So generally, elemental iron is not administered as such. Iron is always present in the form of salts such as ferrous ammonium nitrate, ferrous sulfate, ferrous gluconate. Always iron is chelated with a salt so that it loses its toxic ability. At the same time, it is soluble. If when it is present in the form of salt, it has a better solubility. So, in order to enhance the solubility and reduce the toxic property, generally they will be present in the form of salts. But however, these salts, each and every salt will have equivalents in terms of elemental iron. Okay, we will see what is that. So you should take an elemental iron equivalent, which is around 3 to 5 milligram per kg. So in case of anemia, I'm particularly talking this in case of anemia, not in all the conditions. Okay. So in case of anemia or in case of prophylactic supplementation, you could even take a bit lesser of supplementation, somewhere around 2 to 3 milligrams per kg, which are then divided into 2 to 3 portions per day. So this is also important. So generally, if iron supplementation is consumed after the food, it has a better absorption. And moreover, if they are made into 2 to 3 portions per day, that also has better absorption. So that's why this supplementation should be always performed in 2 to 3 portions. Okay. Then gastrointestinal, what are the common side effects with iron is gastrointestinal disturbances. So they can cause local irritation, abdominal pain, constipation, nausea, diarrhea, and dark stools. So because whatever the unabsorbed iron that people consume will be turned into ferric form. This ferric form of iron is presented in the dark color. So that's why the stools gets dark color. So people should not be feared that they are excreting blood into the feces because of taking iron. So basically, whatever the unabsorbed iron will turn the stools into dark color. Let us now see what are the salts of iron and how much equivalents of iron or how much amount of elemental iron these salts contain. So ferrous sulfate, this is the most common oral supplement, and this contains around 20% of elemental iron. And then ferrous gluconate, and this has the least amount of elemental iron, but it has similar tolerability to ferrous sulfate, and this is also used as a very good iron supplement. So it has 12% elemental iron equivalent. And ferric ammonium citrate, this is comparatively less bioavailable than other ferrous salts, uh, because it must be reduced into ferrous form in the intestine, okay, not in the stomach. Okay. Then apart from that, ferrous sulfate, are also known as anhydrous ferrous sulfate. This is costlier than ferrous sulfate, and it has another added advantage. So it has extended release. So so only once daily of anhydrous ferrous sulfate is sufficient, and it has also more quantity of elemental iron, which makes it a better candidate than ferrous sulfate when in terms of dosage. Okay. And ferrous fumarate, so it contains around 33% of elemental iron, and it has a better effectiveness and tolerability compared to uh, similar to ferrous sulfate. And carbonyl iron and polysaccharide iron, these two are 100% elemental iron. They contain 100% elemental iron, and basically these are purified and purified microparticles of iron itself, and they'll be dissolved in the stomach when they come into contact with the hydrochloric acid. And they are also comparatively longer, means so if you could observe the polysaccharide complex, so once daily elemental iron dose is similar to twice daily ferrous sulfate. Okay, so that means only once daily dose is sufficient enough in the people who consume this. Okay, so these are various forms of iron supplements. And then other types of iron so whatever the iron supplements that we discussed here, all these are oral. Okay, remember this, all these salts are oral supplements. So for the GPAT, there could be some tricky questions to identify which of the following forms is a parental form of iron, or which of these is not a parental form of iron, or which of these is a oral form of iron, or something like that. You should remember which are oral forms of iron and which are parentals. So let us discuss about parental forms of iron also. So these parental formulations of iron includes iron dextran, sodium ferric gluconate, ferriumoxetil, ferric carboxymaltose, and iron sucrose. Okay, so these parenteral formulations of iron are actually reserved for the patients who have chronic anemia and who cannot be maintained on oral dosage alone. So those people who had chronic disease and they just oral supplementation itself is not sufficient. So in them, it is also warranted to supplement the iron through the parenteral formulations. And especially these parenteral formulations are used in the patients who have advanced chronic renal disease requiring hemodialysis. So those people who are kept on hemodialysis, and in them it is also mandatory to give some treatment with the erythropoietin, and those people who undergo post gastrectomy conditions. Okay, means a part of the stomach or a part of the intestine is removed due to any kind of problems such as inflammatory bowel disease, or in case of intestinal cancers or stomach perforations due to intoxications, and many other problems lead to post gastrectomy. Okay, then also people who has small bowel resection and inflammatory bowel disease and proximal small bowel and malabsorption syndromes, and in all these conditions you may need to supplement the iron in parenteral route. Okay, and so this is all about iron. And finally, one important thing about iron is iron toxicity. So if someone consumes more number of tablets of iron, so generally iron supplementation is commonly administered in the puberty. So during the puberty, if let's say a physician prescribes a child who is at the age of 12 to 13 to consume iron tablets. So generally these iron tablets are coated with sugar, so they almost look like gems. Okay, so which makes them highly edible, right? So basically they are coated with the sugar to make them edible and elegant also. People, generally these children may not consume them unless they are edible and elegant, right? So if unknowingly children consumes many number of pills, let's say if a child consumes around 10 pills of iron, that itself is sufficient to kill the child. I'm talking about killing the child. So these are that much toxic, right? So in fact, there are news articles where some children unknowingly took the expired pills of these iron, and they are intoxicated and died also, right? So in those people who unknowingly consume more amount of iron, there is an antidote. Okay, so that antidote for iron toxicity is desferoxamine. Okay, so this desferoxamine is an iron chelator. Okay, it chelates the iron and eliminates in the urine and also feces. Okay, so this desferoxamine should be given to those people who consume greater than 60 mg per kg of iron. Okay, so if someone consumes greater than 60 mg per kg of iron, then desferoxamine treatment is warranted to make them survive out of iron intoxication. Okay, so this is all about iron. Then let us discuss about folate, also known as folic acid, also known as vitamin B9. Okay, so folate deficiency causes megaloblastic, also known as macrocytic anemia. Okay, in this figure you can observe a megaloblastic anemia. Right. So generally, a megaloblast means an abnormally large nucleated red blood cells. All the red blood cells are enucleated. Enucleated means nucleus is removed. Okay, all the red blood cells do not have the nucleus. But if a nucleus containing red blood cell is present in the flow of blood, then that is called a megaloblast. Okay, so generally these megaloblasts would not be formed in a healthy individual, but in an unhealthy individuals are in those people who are deficient with vitamin B12 or folic acid. Those people who are deficient with vitamin B12 and folic acid, you can observe megaloblasts in the flowing blood. Okay, how to identify those megaloblasts? So I hope all of you remember the neutrophils. Neutrophils will have nucleus like this. Okay, so you can observe three nodes in the nucleus. But megaloblasts will have multiple nodes. You can observe there are so many number of nodes, right? So around 5 to 6 nodes, right? So you can clearly observe these megaloblasts under a microscope. Okay, so if someone has uh, megaloblastic anemia, it could be due to folic acid deficiency or vitamin B12 deficiency. Okay, so what actually caused this folic acid deficiency? It is caused by diminished synthesis of purines and pyrimidines. So what are purines and pyrimidines? They are DNA bases. Okay. So if someone has a folic acid deficiency, their uh, uh, their bone marrow doesn't get sufficient folic acid, and this folic acid is involved in the formation of purines and pyrimidines. Suppose if purines and pyrimidines are not available, then cell cycle or reproduction is going to slow down, and sometimes immature cells will be released into the blood. So this megaloblast is an indication for immature cell being released into the blood. Okay, so that could be one reason. And as I told earlier, both vitamin B12 and folate deficiency could cause megaloblastic anemia. That's the reason why if someone has a megaloblastic anemia, the person also need to be tested for neurological complications. Okay, I will tell you the reason why why if someone has a megaloblastic anemia, why they need to be tested for neurological complications. And if someone has a folate deficiency, it could also cause some neural tube deficits. Okay, so one example for neural tube deficit is called spina bifida. Okay, so this spina bifida, in case of spina bifida, you can clearly observe the spinal tube. This is spinal tube has come out. So lady this pregnant lady is deficient of folate. Okay, so during the pregnancy she doesn't consume sufficient supplements of folate or doesn't consume sufficient folate containing food, so which made into uh, s- uh, neural tube deficits into baby. Okay, so this in case of spina bifida, you can clearly observe the spinal tube has come out. Okay, so this deficit is called spina bifida. Okay, so this could be one of the one of the detrimental outcome due to folic acid deficiency, and in fact, one in 2,500 people will have this spina bifida due to folic acid deficiency. Okay, then then let us discuss about how folic acid is absorbed. It is absorbed into the jejunum, and it is also rapidly absorbed, and moreover, high doses of folic acid are non-toxic, not like iron. If you give high dose of iron, it is toxic, but high dose of folic acid is not toxic. However, it is administered at optimal dose. What is the need of giving a high dose? Okay, so let us see how this megaloblastic anemia is produced due to folic acid deficiency. So basically, folic acid deficiency could be due to dietary deficiency during pregnancy or lactation, or poor absorption due to a condition called as pernicious anemia. So a condition known as pernicious anemia lead to poor absorption of iron. Okay. So our alcoholism also leads to poor absorption. And then if someone is on drug therapy such as dihydrofolate reductase inhibitors, if person is taking drugs such as methotrexate or trimethoprim, these are called dihydrofolate reductase inhibitors. So these drugs are actually used in case of rheumatoid arthritis and cancer. Okay, if people are using these drugs for a longer time, that could cause folate deficiency. And if someone consumes anti-metabolites, also known as anti-metabolites are cancer drugs, these cancer drugs such as azathioprine or zidovudine. So these kind of drugs, if someone consume, they inhibit the DNA synthesis, and because of inhibition of DNA synthesis, also folate deficiency could be arised. Are drugs which reduce the absorption of uh, uh, iron, which includes phenytoin and phenobarbital. Okay, so in case of any of these cases, folate deficiency could occur. If folate deficiency is occurring, that could inhibit the or that could reduce the amino acid synthesis, and that could reduce the purine pyrimidine synthesis, and finally that could reduce the DNA and RNA synthesis, because purines and pyrimidines are the backbones of DNA and RNA, and because of this, ultimately it could lead to megaloblastic anemia. Okay, so, in those cases, definitely people need to consume folate. Supplementation of folate is given, right? And then, how this folate is going to act, or what happens to this folate when you consume, right? So, when someone consumes folate, it turns into folinic acid. Folic acid turns into folinic acid, also known as leucovorin. Okay, so this is the active coenzyme of the folic acid. This is used for rescuing normal cells while treating the cancers with high doses of methotrexate. If someone is supposed to consume the methotrexate for cancer or for rheumatoid arthritis, as we discussed, so in that case, they can also be supplemented with the folinic acid so that they won't get the deficiency of folic acid. Okay, and this folinic acid can also be used along with another anti-cancer drug known as 5-fluorouracil. Okay, so the it makes the combination of folinic acid and 5-fluorouracil is synergistic, means it kills more number of um, cancer cells and rescue good cells. Okay, so these are uh, some facts about the folic acid therapy. Okay, then let us discuss about vitamin B12, also known as cobalamin. Okay, so vitamin B12 is essential for the production of blood cells, and also it has another important action. It is important for myelination of neurons. Okay, so nerves have the myelination, or the nerves has the myelin sheath. Axons has the myelin sheath, right? So this myelin sheath acts as an insulation. Okay, if myelination doesn't happen properly, or insulation doesn't happen properly, uh, uh, the people would have many number of non-myelinated neurons. I hope all of you remember the difference between myelinated and non-myelinated neurons. Okay, in the myelinated neurons, conduction velocity is very fast, and non-myelinated neurons, comparatively, conduction velocity is very slow. Right. So because of vitamin B12 deficiency, myelination of neurons will be reduced, which means their myelinated neurons turn into non-myelinated, which could ultimately lead to neural deficits, okay, or neural problems, okay, especially if vitamin B12 deficiency occurs in the children, and they could turn into mentally retarded child. Okay, so because of that, vitamin B12 is very essential for the growing children. Okay, and its deficiency causes megaloblastic anemia. So as we discussed earlier, and we will see how megaloblastic anemia is produced due to vitamin B12 deficiency also, and neuronal demyelination and subsequent degeneration lead to neurological and neuropsychiatric manifestations. As we just discussed, neural deficits are produced, and one of the main reason for the vitamin B12 deficiency is pernicious anemia. So in fact, pernicious anemia could lead to iron deficiency also. But it is very essential for the physician to identify whether it is iron deficiency or B12 deficiency. If the physician identify that the person is suffering with the megaloblastic anemia or pernicious anemia, and they give only iron supplementation and not give B12 supplementation, then that could lead to neural deficits, because B12 is required for the myelination of neurons. So that's why whenever a physician identify megaloblastic anemia, it is very important to identify why megaloblastic anemia is produced. So if the physician identify that it is due to iron supplementation, it is due to iron deficiency, so then the physician can give only iron supplementation. If it is due to vitamin B12 deficiency, then physician can give only B12. Suppose it is not possible to perform a test, because it is let us say it is an additional expenditure to the people who is undergoing for treatment. So in that case, it is better to give a small amount of supplementation of iron and some amount of supplementation of B12, both, and along with that, folic acid also, so which could ultimately make the people uh, not to be affected due to pernicious or megaloblastic anemia. Okay, so this is very important. So if a person has pernicious or megaloblastic anemia, it is very important to understand whether it is due to folate deficiency or B12 deficiency. Okay, clear? Then it could be also due to vitamin B12 deficiency, could be also due to non-specific malabsorption syndromes or bariatric surgery. Bariatric surgery is a surgery of is a surgery to remove a part of the stomach. Okay, so I hope all of you remember the anatomy of stomach. Okay, so this is how your stomach looks, right? So bariatric surgery is removal of a part of stomach. Okay, so this particular part of stomach is removed. Okay, so this is removed because the person has lots larger stomach. If the person has larger stomach, the person consumes large amount of food. If person has smaller stomach like this, the person consumes small amount of food. So there are certain people who undergoes bariatric surgery as a step to curtail their weight. Okay, so in this case of bariatric surgery, some people lose an essential part of the stomach. So this part of the stomach is going to produce a specific hormone known as transcobalamin. Okay, so this transcobalamin is very essential. So we will discuss that in the next slide. Okay, so basically, what are the cobalamin or vitamin B12 that you consume would be from the diet or from the or as a supplement. Okay, so this is your diet, which is containing proteins and also cobalamin. So when you consume that, your saliva uh, is going to have a specific hormone known as transcobalamin, also known as haptocorrin. Okay, your saliva contains haptocorrin, also known as transcobalamin. The function of transcobalamin or the haptocorrin is to protect the cobalamin. Cobalamin is highly sensitive to the acidic environment of the stomach. Okay, so because within the acidic environment, it is going to get degraded. So this cobalamin will be protected by the haptocorrin, also known as transcobalamin. So haptocorrin or transcobalamin is produced in the saliva. Okay, and it enters along with the food into the gut. So within the gut, so this transcobalamin, this cobalamin will be transferred into the transcobalamin. Along with that, from the gut, parietal cells in the gut are going to produce something called intrinsic factor. Earlier, I told you. So a part of the gut or the parietal cells of the gut produces intrinsic factor. Okay, this intrinsic factor is very important for the absorption of cobalamin. So as we are just discussing the transport of cobalamin bound to the food will be transferred to the haptocorrin because it protects the gut. Haptocorrin protects the cobalamin from the acidic environment of the gut, and after it enters into the duodenum, in the duodenum, certain pancreatic juices includes certain proteases which breaks down the haptocorrin and cobalamin. Okay, now haptocorrin is now released. So cobalamin is now released out of the haptocorrin. Then this free cobalamin would then bind to the intrinsic factor which is released by the gut. Okay, so this intrinsic factor would then bind the complex of intrinsic factor and cobalamin would then bind to the cells within the ileum. Okay, so it has to cross the duodenum, jejunum, and finally ileum. So within the ileum, there are certain receptors to which intrinsic factor cobalamin complex is going to bind, and then cobalamin will be absorbed. Okay, now let us see why cobalamin is not absorbed in certain people. Okay, so pernicious anemia, what is meant by pernicious anemia? So in case of pernicious anemia, these people will start producing certain antibodies. So basically, pernicious anemia is an autoimmune disorder. Okay, so in these autoimmune disorder affected people, certain antibodies are produced. What are those antibodies? These are anti-gastric parietal antibodies. So these are gastric parietal cells. Anti-gastric parietal cell antibodies kill the parietal cells. Okay, so they kill the parietal cells and cause autoimmune gastritis. So these people will have gastritis, which is an autoimmune disease. Okay. Apart from that, in certain people, anti-intrinsic factor antibodies are produced. Means antibodies against the intrinsic factor. So in both the cases, you can observe in both the cases. So in this case, parietal cells will not produce intrinsic factor, and in this case, Parietal cells produces intrinsic factor, but intrinsic factor is bound with the antibodies, and intrinsic factor will be destroyed. So because of that, intrinsic factor is reduced. Apart from that, in the people who are suffering with autoimmune gastritis, echlorhydria means parietal cells are the one which produces hydrochloric acid. So because parietal cells are damaged, hydrochloric acid is also not produced properly. Okay, so in these people, echlorhydria leads to reduced absorption of iron. So I told you earlier, in the stomach, iron keeps the HCl keeps the iron to turn into ferrous form, and ferrous form is absorbed. But due to echlorhydria, iron is also not absorbed in the pernicious anemia. Okay, and due to echlorhydria itself, release of cobalamin bound to the diet also will not happen. Means within the diet, whatever the cobalamin is present, it is bound to the diet itself and excreted. Okay, so this could ultimately cause cobalamin deficiency. Okay, so because of reduced intrinsic factor, cobalamin is not absorbed in the intrinsic factor antibody containing people, and because of that, cobalamin is not absorbed and cobalamin deficiency occurs. Okay, so now try to clearly understand, students. In case of pernicious anemia, iron deficiency and cobalamin deficiency occurs. Okay, clear? And in case of another anemia called as megaloblastic anemia. Okay, in case of megaloblastic, also known as macrocytic anemia, folate deficiency and B12 cobalamin deficiency happens. In both the cases, cobalamin is present. Okay. In pernicious anemia, cobalamin is deficient, and in megaloblastic anemia, cobalamin is deficient. But in case of pernicious anemia, iron is deficient. But in case of megaloblastic anemia, folate is deficient. So you should observe that both pernicious anemia and megaloblastic anemia, B12 deficiency is common. That's why it is better to supplement B12 in both the cases of anemia. Okay, and the common symptoms of B12 deficiency include tingling in the hands and feet, difficulty in walking, dementia means memory loss, and in extreme cases, the people also get hallucinations and paranoia, means mental, and schizophrenia also. Okay, so these are symptoms of deficiency of vitamin B12. Okay, so in those people who are having macrocytic anemia, it is not recommended to administer folic acid alone. It is always administered to give the folic acid along with vitamin B12. Okay, and vitamin B12 gets converted into active enzymes such as adenosyl cobalamin and methyl cobalamin, which are involved in the metabolism. So in those people who are suffering with the pernicious anemia, this hydroxycobalamin or cyanocobalamin should be administered through deep subcutaneous route. Okay, not only oral supplementation is sufficient. Through deep subcutaneous route, it should be administered at a dose of 1.5 mg per day. Okay, and B12, is a highly protein bound vitamin, and that's why it maintains a longer plasma half life. So once daily dose is generally sufficient. Okay, but when this B12 is combined along with the other preparations, it might need to be administered in larger doses. But however, just like folate, B12 also doesn't cause any toxicity, even administered a little bit more. Okay. Then some other hematinics include, apart from the iron, B12, and folate, some other hematinics include erythropoietin. Erythropoietin we have just discussed in the very beginning of this session. So erythropoietin is a hormone produced by the kidneys which stimulates the erythropoiesis. So if someone has an anemia uh, due to the deficiency of erythropoietin, are patients who had chronic renal failure, are HIV infected people who are taking giroburin, are cancer patients with myelosuppressive therapy, are patients scheduled to undergo non-vascular surgery, are cardiovascular not, and undergoing non-cardiac surgery. In those people, erythropoietin is administered in the form of derbepoietin alpha. Okay, so these are administered in case of all these cases. Okay, and then another case where neutropenia occurs. Okay, neutrophils are reduced. Okay, or in case of stem cell or bone marrow transplantation, or in case of mobilization of peripheral blood progenitor cells. In all these clinical conditions, um, and another drug known as filgrastim is administered. Okay, filgrastim is a granulocyte colony stimulating factor. Okay, so it stimulates the granulocyte colonies to produce more number of granulocytes. Okay, I hope all of you remember what are granulocytes and agranulocytes, right? So, so all these eosinophils, basophils, and neutrophils are granulocytes. Okay, so granulocyte colony stimulating factors such as filgrastim stimulates the granulocyte production. So in case of neutropenia, neutrophils are produced in those people who require them, right? So particularly in cancer patients, are patients with severe chronic neutropenia, are patients undergoing bone marrow transplantation. So all these people. Okay, then interleukin 11, also known as opral vecin. So this is particularly administered in case of thrombocytopenia, in case of platelet deficiency. Both interleukin 11 and romiplastim are administered. Okay, in the people who are having idiopathic thrombocytopenia means unknown cause. Okay, or in case of malignancies. So in these cases, you can administer these kind of erythropoietin. Okay, so along with this presentation, I also given a summary of whatever we just discussed. So let us just have a brief summary. Iron, it is given in the form of salts such as ferrous sulfate, ferrous gluconate, and etc. And it is involved in the synthesis of heme and proteins. It is bound to hemoglobin and myoglobin, and the effects due to inadequate supply of iron include iron deficiency anemia, and in the iron deficiency anemia you can administer this, and you can also observe microcytic anemia in case of iron deficiency anemia, and these are available in the form of oral preparations, and there are parenteral preparations of iron also available, which are called as the iron dextran, sucrose, sodium ferric gluconate complex, ferric carboxy maltose, and ferrumoxetyl. So and ferrous gluconate and ferrous fumarate are oral preparations. So it is very important to identify the uh, uh, mm, need and give the iron supplementation either orally or parenterally. And iron toxicity could be causing gastroenteritis and abdominal pain, bloody diarrhea, and it could kill the patients also. So to reverse the actions, you can administer an iron chelating agent called as desferoxamine. So desferoxamine is an iron chelator. And vitamin B12, also known as cobalamin, it can be supplemented in the form of hydroxycobalamin or cyanocobalamin. It is an essential cofactor for the synthesis of many metabolic enzymes such as and L-methyl mannan CoA, and in case of vitamin B12 deficiency, as we have seen, it could cause megaloblastic and pernicious anemia. And vitamin B12 need to be administered parenterally in people who are having a pernicious anemia, because they cannot have sufficient absorption due to autoimmune antibodies being produced. And generally no toxicities are associated with the vitamin B12. And then folic acid, also known as folinic acid. Um, so this is a precursor for the synthesis of purines and pyrimidines. And due to the folic acid, I mean, lack of folic acid can cause reduced purine and pyrimidine synthesis, and because of that, megaloblastic anemia is produced, and even neural tube deficits are produced. These are problems with the deficiency of folic acid, and once administered orally, it is well absorbed, and folic acid doesn't have much of toxicity. And as we just discussed earlier, erythrocyte stimulating agents such as epoetin alpha, also known as erythropoietin, or also known as derbapoietin alpha, right? So these erythrocyte stimulating agents stimulates the erythrocyte formation in those people who are having chronic loss of blood. Okay, and granulocyte stimulating factor also we have just seen. So these are all hematinics. So if you have any doubts related to this particular class, you can ping me in WhatsApp, or you can comment below this YouTube video. So thank you for your patient listening. I hope you enjoyed the class.